future of public health teaching. Dr. Galea?
Well, thank you very much for having me. Thank you, Dr. Hu. And as Howard mentioned, we've been friends and colleagues for a very long time. So really is a treat to be invited to speak to you. I'm only sorry that I cannot be out where you are, which is lovely. So I did ask Howard to make sure that this is really a down payment on being invited to come actually speak to you at some point in the future where I can be there in person. So Dr. Hu asked me to speak about everything about the future of academic public health. And he said, just make sure you do it in under 30 minutes, which I thought that shouldn't be a problem. So I'm really doing a bit of a overview, big picture talk. I did want to keep it to under 30 minutes because I want to make sure that we have time both for reflections from the panelists, but also for give or take from the audience. And I'm going to try to combine both a bit of a big picture view of what I think are pressing issues in public health that I think are going to shape what we do, how we think, and how we educate, but also practically where education is going in within the programs and schools of public health. So having said that, let me share my screen. Please let me know if there's any problem sharing. So I'll start with where we're at in the health of the public in the recent past. And we are all maybe hopefully emerging from COVID times, which makes it really difficult to realize anything about the health of the public other than the fact that it's been bad, and we've been running around with our hair on fire for the past year and a half. But the truth of the matter is that actually in the main, the world is actually doing well on the health of the public, and in large part because of the work of public health. This is looking at global life expectancy and the longest time series on life expectancies in the United Kingdom, which is the purple line. It is important to remember that life expectancy until really 150 years ago was about 40 years. And the fact that we've had a doubling of life expectancy, there's actually a new book that just came out by, I believe, Stephen Johnson on this, which is all really due to public health, is quite extraordinary. And Stephen Johnson, I did a book Q&A with him a few weeks ago, and the point he makes is the doubling of human life expectancy because of public health should be the headline of every newspaper every day. He does this thought exercise, which says, supposing that there was one newspaper issued every 100 years. Suppose this newspaper only comes out once every 100 years, right? And you had a newspaper in 1900 and you have a newspaper in 2000. Well, what's the most dramatic story between 1900 and 2000? The most dramatic story is people used to die at 40 and now they're dying at 80. That's the news story. And that really is the work of public health. And I think that's important to remember. And I think it's important as a result for public health to assert its presence as having made real important contributions to the world. Now, as everybody here knows, that's due to many, many things, not the least of which is the tremendous decline in child mortality, again, in the past 100 years, but particularly in the past 200 years. This just gives you a sense of the extraordinary decline in child mortality. And also the drop in many practically changed risk factors, things like smoking, which has been decreasing all over the world, although increasing in some countries, as everybody here knows, which has made an enormous difference into the burden of disease worldwide. This is the relative decrease in stroke linked, of course, to drop in smoking. We've also had success with infectious disease like HIV. I mean, HIV was the previous pandemic to COVID-19 that galvanized the world 40 years ago. And HIV was dealt with, became a chronic disease. It obviously remains a troubling chronic disease. And in parts of the world, like centrally sub-Saharan Africa, it remains a really important cause of morbidity and mortality. But fundamentally, number of new infections from HIV/AIDS have gone down, and people living with HIV/AIDS have gone up as it has become more of a chronic disease, as we have achieved and developed ways to actually deal with HIV, both in terms of treatment, but also in terms of prevention with things like PrEP. So that's the sort of triumph of public health. And I really feel like, one of the challenges always with any of us ever giving public talks is that we are sort of harbingers of doom, right? It's like, we come in and we speak and say, the sky is falling, health is bad. And then that's sort of what we're asked to speak. And I'm trying to really change that to say, we actually are part of a proud disciplinary tradition that is doing the world well, and that the world is much better as a result of our work. And then, of course, comes COVID. And the past year and a half, roughly, all we have been thinking of is like, if you think of the pie chart of our brain, I feel like it's like the 90+% of my brain now is COVID all the time. And I'm sure it's the same for all of you. And COVID has had a real impact on the health of the public. This is life expectancy at birth by race. And first, I'll note the racial ethnic differences in life expectancy, which I'll get to in a second. But in particular, I'm showing you this to look at the dip, at the COVID dip in life expectancy. And if I were to show you a full 100-year trajectory, what you would see is that actually we did have a small dip over a 3-year period in 2016, 17, 18, which was the first time we had had a 3-year dip since the 1918 flu pandemic. And then we're having this big dip in 2020, which really mirrors the large dip in life expectancy that we had with the 1918 flu pandemic, roughly 100 years ago. And as everybody here knows, this dip in life expectancy, consequences of COVID, have not been felt equally. In fact, if there are the 3 top stories of the COVID moment that are going to stay with us, and I think it's important that we in public health are clear about this, the 3 top stories going to stay with us in COVID moment are equity, equity, equity. I mean, this is really going to be, insofar as COVID is an X-ray on our state as a society, COVID has revealed deep inequities that we knew were there, but it's sharpened them and made them clear in everybody's minds. These are things that we in public health have long known, but the world is now waking up to them. And I think it's going to shape and color what public health does and how public health thinks. Just to quantify that a little bit, this is from CDC, from MMWR, looking at the change in life expectancy at birth as a result of COVID, where you see Black men at about a 3-year change in life expectancy, while we're dealing with non-Hispanic white men, you're dealing with 0.8, non-Hispanic white women, only about 0.7. So a tremendous decrease in life expectancy, differential by race and ethnicity as a result of COVID. And of course, as a result of COVID, we're not just dealing with COVID alone. We're not just dealing with COVID as an infectious pathogen and morbidity and mortality due to the virus itself. We're also dealing with the change in morbidity and mortality in a range of other conditions. This is looking at strokes and Alzheimer's and diabetes and hypertension. And what you see in this graph is the blue bars are mortality during the 2020 year, and the dark blue line is the previous 5 years rolling average. And what you see is that mortality from all these other conditions has also been up in a time of COVID. There's many reasons for that, in no small part inattention of the health system, but also probably the accrual of health risk behaviors that ultimately resulted in these other conditions also getting worse. And then last, but definitely not least in a time of COVID, has been the growth in mental illness. And this is from work actually our team had done, looking at and showing a 3-fold increase in depression in a time of COVID. This was consistent with, replicated by then many other groups, including CDC, in CDC's pulse surveys that they've done using a screening measure. Roughly, there is consensus, I think, at this point that there's been about a 3-fold increase in common mood anxiety disorders in a time of COVID, which, by the way, just to give reference, in other large-scale disasters, the most you ever see with things like that is about a 2-fold increase. So a 3-fold increase is really quite remarkable. The studies are just beginning to emerge as to how that has changed over time, but probably I think it's a safe assumption that during COVID, that these prevalences remain just as high consistently over the year plus of COVID, which is again unheard of. So COVID, so the world's doing well, doing better with deep inequities. COVID hits, deepens the inequities, and all of a sudden we have a setback in much that we do in public health. That's really, I think, the state of where public health is at. Now, I suspect that all of you on this call, because you're all public health professionals, you all sort of know this, and I realize I'm not saying anything new, and I hope you'll bear with me in articulating it. But if I'm to lay out an argument for where the future of academic public health is, I don't think we can make that argument without thinking about where are we at as a field, because not only it's important as a starting point for our education, but I think it's what our students are expecting. I think our students are coming in with this realization. It may not be sharply focused realization, but they see this and they understand this. And I think they expect us to meet them where they're at, and they expect us to build their education on this appreciation of the world. Now, the other element that I think COVID has surfaced, and I think it is perhaps one of the silver linings of COVID. It's very hard to say silver lining about a disease that has killed 600,000 Americans, right? It's a devastating disease, and one around which the only appropriate response is grief and sorrow. But at the same time, through a moment like that, we need to emerge with learnings, because if we do not emerge with learnings, then truly, it's a wasted moment. Then truly, it's a moment of just grief and sorrow without us learning, us advancing, and us evolving. And I think one of the elements that has emerged is a greater appreciation of the foundational causes of health, which is, of course, what we do in public health. So COVID, while being a public health emergency, has also been an elevation, a sharpening, a clarification of what it is that we do in public health and why the world should care about the forces that create health, and why, as a result, public health should be front and center. Because fundamentally, the health of the public is not about medicine. It's not about healthcare. It is in part, it's 10, 20%, but the health of the public is about health behaviors, about physical environments, about socioeconomic factors, about education, job status, where you live, where you work, where you play, whether you drink, sexual activity, tobacco use, the characteristics of your built environment. We all know that. We all know that as a world. We all know as a public health profession, but it's been difficult for the world to see that. And COVID, by elevating the inequities in the burden of COVID, has shown that much of health is not the biology, much of health is not the curative approach, but it is the world around us. And this, of course, plays directly into the middle of what we do. This is us. This is what we do. This is a vision of public health. There's many different labels for this. Public Health 3.0 is a term that had come out from Health and Human Services. But this is a modern conception of public health. And I think academic public health is at this moment leaning heavily into this. And this is what our students are expecting. And this is the kind of education that I think we need to develop for our students. The challenge is that as we do this, just taking a purely domestic lens, we can talk globally as well. The country is sort of countered this, right? This is spending in the US, and leaving aside Social Security, you see healthcare programs, aka curative health, is going up, while all other spending on all the other pillars has been going down. Now, there's been changes to this, and with this current executive branch moving on things like infrastructure, there might well be changes to this. So it is then a dynamic and interesting time. So that's fundamentally the picture of what is driving health right now. But the other element of the fundamental causes of health, our societal underinvestment in them, is that insofar as there's societal investment, it is uneven investment. And that uneven investment has resulted in deep inequities in health in this country. Those deep inequities are on socioeconomic axes and on racial ethnic axes, and one can calculate them, one can show them in any number of ways. The way to read this is the dark blue line is Black Americans, the lighter blue line is white Americans. And what you see is unemployment consistently higher over time for Black Americans than white Americans. Conversely, college completion higher for white Americans than Black Americans, household income higher for white than Black, home ownership higher for white than Black, imprisonment higher for Black than white, life expectancy higher for white than Black. And one could go on and show many such pictures. And of course, this goes hand in hand with, is part and parcel of, with a historical view of health that is ultimately recognizes that health today is generated over a life course, over generations, and comes all the way back, goes all the way back to the original national sins of marginalization, discrimination, enslavement of particular groups. This is a map looking at enslavement of Africans in 1860. And you cannot really tell the story of health in this country without telling the story of centuries of marginalization of particular groups, centuries of disenfranchisement of particular groups from accumulating the assets that they need to generate health. And this, to this day, I mean, today there's a lot of sort of linguistic, I think, jostling for space around this. And the term systemic racism is a term that actually has emerged to the fore, which I think is perfectly accurate phrase that ultimately reflects a societal structure that has systematically excluded particular groups, in this case, Black Americans, from the assets and resources that makes them healthy, from the assets and resources that creates health in those populations. And this is very much at the heart of public health. And I would have said this had you invited me in 2015. In fact, this is a slide from a slide deck from 2015. But the world is now seeing this as self-apparent. And I think public health education needs to now lean into this. I think our students are expecting it, and I think it can become part of the core of how we see academic public health going forward. And of course, COVID has been the perfect storm of a disease that ultimately exacerbated these underlying inequities. This is change in employment by income group in COVID. And what you see is there was a drop in employment for everybody, but the wealthiest 25% recovered very quickly, while the bottom 25% remains about 20% below what it was before COVID. Because of course, the lower income wage jobs, which are in retail and construction and in areas like that, have not recovered in a time of COVID. There's another way of looking at it, which is jobs gained and lost by millions. Notice that in the highest income quarter and the second income quarter, in other words, in the top half of earning jobs were actually gained in a time of COVID. Jobs were lost in the lowest two quartiles of income. And the other element of this that COVID really has highlighted is the fact that not only is our societal structures central to creation of health, COVID has made it abundantly clear that we as a world have, as a world, I say as a country, because I'm focusing here domestically, we can talk globally in the Q&A, have been underinvesting in the public health infrastructure that could have helped. Broadly speaking, the title says this, the state and local governments spend less than 3% on public health. We spend substantially less than things like hospitals, things like policing, things like highways. In fact, most local governments spend more on policing than they do on health. The way to read this is that the red are counties where there's more spending on policing, and the blue are the relatively few counties where there's higher spending on hospital health. So this is the picture of the world that was true in 2015, was true in 2010, was true in 2000. But COVID has made it clear how important this is. And COVID has made it clear that we in academic public health have a moment to now lean into the underlying structures that generate health, lean into a world which has underinvested in public health, to both teach this, but to prepare the next generation of students that are going to be the people who are going to advance these causes forward for the next 40 years. Because remember, when you train students, they're going to be in the field and leading in the field for at least 40 years. So let me switch to academic public health with that background. So where is academic public health at? So this is the number of accredited programs in public health, which has really increased dramatically. Which you see the inflection point was around 2000, that the programs of public health grumbled along for a little bit of time. And then really there's been an explosion in the past 20 years. And as Dr. Hu mentioned in the introduction, my introduction, I served for 2 years as the chair of the board of the associations of programs and schools of public health. And that association, we used to be called the Association of just Schools of Public Health, but then became Schools and Programs of Public Health about 5 years ago, really at a time when there became more programs of public health than there were schools, where really there was this tipping point with more programs than there were schools. These are sort of the accredited programs, remain largely dominated in North America, although that's changing, and I think that's actually slowly starting to spread. And I just want to show you some application trends. And application trends had been holding pretty steady. And the way to read this is this sort of number of applications that go into SOFAS, which is the common application system, over the year. You start from August and you go to August. And these are cycles. These are sort of by different years. And what you see, I want to show you two things, because I do think this is important in the context of places like yours, where you're thinking about evolving your academic program, that the cycles were always going up. You see over here to 13, 14, 15, 16, 17, 18, a number of applications were going up. And then in 2019, which is cycle 13, which is this line right here, there was a drop in applications. So 2019 went back down to where we were at in 2017. Then COVID hit, and then 2020 happened, and then 2021 happened. And 2021 has roughly a national increase of about 30% in number of applications. So it is important to keep that in mind. And at ASPPH, we had many conversations about what was happening in 2019. And we had quite a bit of hand-wringing about whether or not public health was facing the fate of law schools that had sort of saturated its audience, and why that was. And we can talk more about that in the Q&A session. But there has been volatility in the student demand for public health. There certainly was volatility before COVID hit, and now demand for public health is sort of off the charts. But we can talk more about that, but I think it's important for this group to be aware of that. A couple of other things that I think are important is that the demographics of students in public health are changing. I'm actually not showing you gender here, but gender has changed dramatically. I think everybody here knows that, in that the overwhelming majority of graduates now are women compared to men. But leaving that aside, I just want to talk a little bit about race and ethnicity. That in 2019-20 was the first year where in the US, the percent of matriculants was, there was no majority group in percent of matriculants. That the white matriculants was 49%. And you see the increase to Black African-American matriculants, 15%, and Latino matriculants, about 13%. So this, the way to read this is 16 all the way to 2020. So for the first time in 2019-20, there was no majority group of matriculants. And when you look at the pandemic, you see even more of a deepening of that trend. And what you see here is, this is August to March 15, 2020. This is March 15 to August 4th. And so this is before this, and which, sorry, this is after this, and you see more Black applicants, more Latino applicants, and fewer white applicants. And I think that's reflecting, broadly speaking, this growing societal awareness of the injustice of COVID. And I think it has really motivated a generation of young students of color who are interested in public health. I just think this is just a fantastic development. Like, it's really excellent that public health, ultimately representing the health of the public, is now attracting people all over, from all over the population. And we're seeing these demographic shifts, I think, representing the population. A couple of other notes about education, because some things that we actually don't think about very much, in that undergraduates are soon about to overtake graduate degrees in public health. This looks at doctoral, undergraduate, and master's education, that the number of undergraduate bachelors in public health is about to overtake the number of master's graduates in public health. But there's a real difference about undergraduate graduates and where they come from, and the graduates where they come from. So this looks at public schools on the left, private schools and programs on the right, and the master's is the dark blue, and the bachelor's is the, I don't know what that color is, it's like light blue, or and what you see is that almost half of the graduates of public institutions are bachelor's graduates, where very few of the graduates of private institutions are bachelors. So what you have happening across the country is a growth in undergraduate public health programs in public universities, many of them regional public universities. And that, by the way, is accompanied by graduates from undergraduate programs ending up principally in the private sector as a pathway. So you have this large number of undergraduates that are finishing with an undergraduate bachelor's and then find themselves working in the private sector. Just to talk a little bit about the revenues and how this affects schools and programs of public health. Now, this is not updated to the past couple of years, just because these things always take some time and have a little bit of lag time. But what I'm showing you here is restricted versus unrestricted revenue. The restricted revenue is the pink, the unrestricted revenue is the greenish. And restricted revenue typically is grants and contracts. So restricted revenue is extramural funding that is earmarked for particular functions. The unrestricted revenue from in schools and programs of public health is overwhelmingly education, with typically some philanthropy. And the philanthropy is very heavily weighted to a couple of schools who have substantial proportion of philanthropy, with everybody else really being a very long tail in philanthropy. So really, we can think of the unrestricted revenue as being principally education. And what you see is there's been a growth in unrestricted revenue across the board, across schools and programs of public health, representing really this growth in education. And to be specific, this here looks at tuition and fees, which is the darker blue, now part of the sort of the blue bar, and you see the growth in that the tuition and fee part of this throughout the years. That's been true in public institutions as well as in private institutions, where there has been this systemic growth in revenue as there's been this increase in tuition in all these schools. Of course, that growth in revenue comes with growth in costs, so we can talk afterwards about what that means for schools and programs. But these are the reality in the moment. So just as a snapshot from ASPPH, just to give you a sense, there are about 54,000 graduates of ASPPH member schools and programs of public health. About 73% of graduates were employed in the first 6 months. Different schools and programs have different expectations. And about 20,000 master's degree graduates. And what I want you to point out here is where people are going with master's degree graduates. And you see the primary employers are healthcare, private sector, academia, government, and nonprofit. So I did want to point this out because I do think that this is not well understood in our field, that if you assume, I think correctly, that healthcare institutions largely function like nonprofits. I realize, of course, that many of our healthcare institutions are nominally nonprofit, but we all realize that ultimately they have a very particular profit motive revenue. They put their profit back into the hospital healthcare system. If you add those two, healthcare and corporations, so that's 48%, 49%, in many of the leading schools and programs, essentially, the majority of the graduates, the master's graduates, are working in healthcare systems or in the private sector. That is an important observation, I think, which influences how one thinks about these academic schools and programs. I can tell you in our school, and I'm happy to talk about our experience afterwards, when I first became dean about 7 years ago, and I presented these data to our faculty were actually quite stunned by that when I said, look, most of our students are actually going in the private sector or in healthcare, because we as faculty don't think that way. We as faculty think, well, students are going into the academic world or they're going into government or nonprofit, but that's not the reality. The reality is that most of our students are going to healthcare and corporations. And I can tell you, by the way, in my school, that number is more than 50%. When you add the two together, it ends up being more than 50%. Overall, it's about 48%. This just looks at the same thing, but I just want to show you the this breakdown by master's, bachelor's, and doctoral. So master's is the orange, bachelor's is the light blue, and doctoral is the dark blue. And there's differences to where people go. So master's graduates, which is the orange, this is the top employer of master's graduates is healthcare organizations. The top employer of doctoral graduates is academic institutions, and the top employer of bachelor's graduates is for-profit organizations. I mean, you see there's a lot of bachelor's graduates also going in healthcare organizations, as well as bachelor's graduates going in academic institutions where they're doing typically project management type work. But the leading employer of bachelor's graduates is for-profit, and the leading employer of master's graduates tends to be healthcare organization. But the two together, hopefully the key message is that you see that the two together really matter. And then just one last point on this, on academic schools and programs of public health. I did want to make the point because I find that now you all may know this, and this may be redundant for this group, but whenever I share this slide, I particularly like showing this slide to our colleagues in medicine, that M.P.H funding per full-time faculty member in public health exceeds that of any other typical school in any large university, and by a substantial amount. So while I've been talking here about education, was in part I was asked to talk about education, I did want to point out that I think the future of academic public health is actually quite bright in terms of its capacity to generate world-class, top-quality, extramurally funded research while balancing that with the growth of interest in education. So I want to sort of conclude by talking a little bit about the content and form of our ideas, because I do think that this ultimately is important as we think curricularly, and to think, okay, if there is this growing student interest, what is it that we're teaching them? I started off by pointing out where the state of the world is at, and I think where our students are at, but what about the content and form of our ideas, and what does that mean for what our students will see? There is this project that's ongoing, which is the ASPPH Framing the Future project. So Framing the Future was initially done 10 years ago. It was chaired by Dr. Julio Frank, which was really an effort to articulate where the future of public health is. Now, ASPPH, we launched this, and we're redoing it's being chaired by Dr. Lisa Sullivan, who's our Associate Dean of Education, really to articulate what is the future of public health education. This hasn't come out yet, but broadly speaking, the areas that the group is looking at are these three areas, which is thinking about education through a lens of inclusive excellence, through an anti-racism lens, thinking about transformative educational models, and really thinking about the reach, visibility, and impact of the field of public health to expand well beyond what was the traditional remit of public health. And hopefully you all see how that is reflected in how I set up my presentation here, which is why I set up my presentation the way I did. Look, we are at a moment in time of extraordinary turmoil. I mean, we have 2020 witnessed the largest civil unrest the country has ever had. Just in terms of about 20 million people participated in some form of mass protest in 2020, which on a population proportion is larger than ever, much larger than, for example, 1968. So this is a real moment of civic engagement around important core issues for the world that are important core issues at the heart of public health. It is reasonable then for us to expect that our students will expect us to engage with these issues, and it's reasonable to think that this should inform our thinking and create the content of our education. For those who are interested in this, we've now done, this is our third in a row symposium on teaching public health. This next one's coming up on Monday, June 21st. It's all available on Zoom. And we have a number of speakers who are sort of talking about, and we choose different topics every year. This one is about transformative educational models, and you're all welcome for that. These things are free and open to the public. I did want to make one point about the story of public health as I start to conclude. These are one of the challenges that I think we have in public health is that the story of health is told as the story of medicine. These are just pretty random books selected from Amazon. I think medicine has been a much more muscular profession in engaging with health in the public space than has been public health. But I think it's going to change. And I think our students are going to change that. It's a generation of students that is much more activated than all of us of the generations I suspect we are on this call. And I think we're going to see the story of public health being told. And I think it's our responsibility to teach our students to tell the story. And as the story unfolds in the next 40 years, which is really, again, the time when our students are going to be active, I think we have a responsibility to think about what are we preparing them for? And it's very difficult, next to impossible, I think, would be sheer hubris to think about what the issues they're going to be facing in 40 years are. But we do know there are trends, there are key trends that are important. There are trends like urbanization that is shaping the world immensely. There are trends that around climate change and changes in the planet. The trends around population migration and trends around changing population demographics and population aging. Like these are large scale forces, migration, urbanization, climate change, and population aging that are going to really result in a different world 20 years from now than it is now. And that, of course, is going to translate in a different public health. And I think it's on us to actually prepare our students for that. Before I conclude, I did want to end with a couple of challenges that I thought is worth reflecting on. When Dr. Hu approached me for this, and we had a chat about where USC was at, and I had the privilege of knowing Dr. Samet pretty well, so I've sort of all had a sense of USC and where you're all at, and deep respect and admiration for what you all do. And I think you're in an exciting phase in terms of thinking about how you engage with education, academic, public health going forward. I just sort of think that's just super cool to be able to do that at this moment in time. But as a result, I think it's important to actually reflect on the challenges that the field has, because hopefully I've presented some of them, but also presented opportunities. But I did want to reflect on a couple of particular challenges that I think affect the field of academic public health at this moment in time. I'll start with this. Look, we're coming out at the end of COVID. And what this looks at is how different groups did on multiple axes: mental health, personal finances, job security, take-home pay, physical health, personal life. Below the line means things that got worse. Above the line means things got better. I want to point out that during COVID, this cluster here are those of us who did better during COVID. And that is essentially people with postgraduate degrees. That is faculty. That means we, as a group, as a social group, really are emerging from COVID wealthier and healthier than before the pandemic, which is different than everybody else in the rest of the world. So I actually think we need to, at this moment in time, particularly recognizing the social challenges and transformation going on in the world, recognize our privilege. And I think the world's going to expect us to recognize that privilege. And I think it's appropriate that we recognize that privilege. That, of course, comes on the backdrop of enormous division in the countries, which affects us because we cannot engage in issues around inclusive education in a world which is urbanizing and aging without recognizing that a lot of these issues are political issues, and the world is much more polarized, making political discussions much harder. This looks at ideological, consistent liberal, consistent conservative positions, Democrats, Republicans, 1994, 2004, 2014, showing the separation of those groups. And we in the academic world are not really representing the world out there insofar as the country is represents these two ideological positions. We are, this looks sort of through a series of questions from inside higher education, far left position, left positions, middle right, far right positions. And you have professors, associate professors, assistant professors. We as faculty body are left. And not only that, you see this assistant professors come in, and then we become more left as we go to associate, we become more left as we become full professors. And I do think this has real implications. In fact, I'll show you the implications of that. These are data. This is actually from our own school. So I'm showing you a little bit of our dirty laundry in the spirit of friendship and the spirit of you all knowing how we're doing. So we ask every year, we do a school survey every year of our faculty, staff, students, alumni. We do it anonymously. And we ask a whole range of questions. You can imagine one of the questions we ask is, people of different X are accepted socially at Boston University School of Public Health. And we have staff, faculty, students, and we have people of different genders, sexual orientation, socioeconomic backgrounds, religions, races, freedom to express sexuality. And what I want you to see is they're all over 70%. And in fact, almost all of them are increasing in faculty, staff, students, except for people of different political views. You see that? And people of different political views are under 50% in terms of staff, faculty, students saying they're accepted. And in fact, we're doing worse as a school. And that pains me. And it pains me even more, actually, because I actually showed that to the school last year. And I said, look, we're doing badly on this. And then we did it again. And we're doing even worse than when I said we're doing badly and we need to fix it, which, of course, as a dean, nobody ever likes that. But I think it reflects the moment that we're in. And I think it reflects how hard we have to work to make sure that actually we are being institutions that help generate thought and think about populations and embracing a plurality of ideas and recognizing these deep divisions in population, making sure that people feel comfortable having those kind of conversations within our walls. I'll stop there. If anybody's interested, this is, I apologize, it's a little bit of sort of a self-promotion, but it seemed appropriate in this context. This is a book on teaching public health that Dean Lisa Sullivan, our Dean of Education, and I did a couple of years ago. It's a compilation of essays, and some of you here on this call are actually contributed chapters to it, I think, and really on different perspectives on, it's not about the content public, it's about the form and the ideas of teaching public health. And I think it's there might be things that might be worth people browsing as you're thinking about developing academic programs. That's it. I will stop there. I will stop sharing. It's really a privilege to be here with you, and I'm happy to, I look forward to listening to the conversation.
Sandro, thank you. What a tour de force. That was fantastic. It's basically our entire Foundations of Public Health course condensed into 32 minutes. Love it. But without further ado, let's get to our panelists. Each one has been invited to give a reaction, ask a question, and to bring to this experience their own experience. Let's start off with Richard. Professor Watanabe.
Thank you very much for that, Sandro. It was tour de force because it covered almost everything that we need to be thinking about. I wanted to ask you a couple of things. The second to last slide where you talked about your survey and the fact that you weren't doing well in terms of the diversity of ideas in terms of politics. This is, as you know, becoming a more and more contentious kind of thing at least out in the public. And it starts to get a little more difficult when teaching how politics intertwines with public health. And I wanted to get your perspective on how do we improve our teaching of the role of politics without engendering some of that contention that's out there where people are pointing fingers at each other just because they're of a different political view.
Yeah, it's a terrific question. I wish I had an answer to you, but I don't. We recently, I'll be candid, we are in real time trying to figure out how to address that question. We recently just launched a series of conversations with our faculty, our staff, and our students separately, which we call the Healthy Conversation series. And they're moderated, structured conversations that are intended to help faculty and staff and students have conversations about how to have conversations. They've actually been quite interesting and quite useful. So it literally, we launched this 2 months ago. So this is something that's evolving for us. I think we need to do that together, but I think it's very tricky to do it together. And it's particularly tricky with incoming students because they haven't been socialized yet, and they come in with with and oftentimes rigid clarity about what they think is the right answer. So I label what we're doing as a way of perhaps revealing that we are uncertain what to do, also revealing that I think it's difficult to do and that it requires constant maintenance.
Yeah, I'll do as just a quick follow-up. I'll just share with you. I one semester taught in our undergraduate health promotion class. And as part of the class, I started each lecture with a health in the news segment where I plucked health items from public health items from the news to stimulate discussion about the role of public health in society and different public health issues. And about a third of the way through the semester, I had a student come to me and complain that I was being too liberal in my views. And the reason they cited was because I pulled my health news items out from CNN or NPR. They were kind of missing the point that I was just trying to come up with a public health issue that they should think about and not really pay attention to where the story was published. But the student was more concerned about where the story was published than the topic that at hand. And that introduced me to this problem that is becoming more and more prevalent and having to be dealt with in some form or fashion. So.
Yeah, that is very sobering indeed. And in fact, that raises immediately this whole related topic, which is the so-called epidemic of misinformation, something that we've started to study, but that in fact is also part of this entire conversation about where does politics and public health intersect. Okay, let's go to Luanne, Professor Rohrbach.
Thank you, Howard, and thank you so much, Sandro, for your presentation. As always, it was really stimulating. And also, I just want to say thank you for your leadership in this area. I've just been so impressed with it. And we all thank you very much for it. So I'm going to just sort of draw a couple of points from your talk and then pull them together into a question. And I guess where just to point out one of the perspectives or a couple of the perspectives that I'm coming from, here we are, a public health program in a school of medicine. And my own role as the director of the Master of Public Health program involves a lot of different hats. But I guess right now I'm going to focus on the hat that thinks a lot about curriculum and also career opportunities for students. So in your talk, you mentioned social determinants of health and the extent to which health behaviors and environmental factors and so forth can account for many of the health problems relative to medical care, clinical care, health care. You talked about an increase in spending in health care and an underinvestment in public health over time. And at the end, you said the story of public health is the story of medicine, and when you showed some covers from books. But I guess also I'm really intrigued by these results that, as you pointed out, are interesting, that our students from public health programs in schools are going into jobs in predominantly in healthcare in the private sector. I guess I wonder here, so here's the question. Well, one more thing. The COVID pandemic, I think, has in many ways encouraged a greater union between the public health field and the clinical care field, by virtue of it, of the nature of the pandemic. So I'm wondering, are we teaching the right things in our schools of public health to prepare students for these careers in healthcare? And I wonder what we know about what those jobs, those jobs in healthcare and the private sector look like, how sort of public health oriented are they? And, you know, are we helping to move the world more towards a population health perspective in healthcare by having more folks go into, public health folks go into the healthcare industry?
Yeah, let me, so first of all, thank you for your kind words, Luanne. I struggle with this a lot. I struggle a lot with whether we are preparing our students for careers in the health sector and in the private sector. Let me start with the latter, because I think the latter is an easier answer. I think we're definitely not on the latter. I actually think that we are ill-equipped as faculty academics to teach students about being prepared for a career in the private sector, because most of us have actually not been in the private sector at all. And, you know, we're in public health where we have a little bit of skepticism about the private sector, let's face it. So I actually do think that that calls on creative imagination about how we do that. And we've done some things in our school, including creating a structure to create more partnerships with private sector, for example, in no small part recognizing that reality. So that's the private sector. Now let's talk about healthcare. I also think that's actually very interesting, because as the field of public health has professionalized, one of the good things about it is that it's moved away from people with medical degrees like myself into people with sort of PhDs and doctorates in public health more directly in public health. So that's a really good thing. But as a result, we are separating out more and more from the clinical world. And there are fewer of us who have the direct link to clinical. And I saw in the chat some questions about how do you integrate public health and medicine? And the answer is with difficulty. But our students, because of what they're doing, I think they have reason and right to expect it. So I do think, you know, one of the things that's talked about a lot, and certainly CFD accreditor talks about a lot, is interprofessional education. If I'm to be candid, I think a lot of people talk a lot about that, and very few people do anything good about that. I'm just being candid among friends. I realize it's being recorded, so don't get me in trouble. But it's because it's hard to do. It's actually hard to do, and you know, it's one of those things. I mean, you have many schools of public health with a lot of smart people. I sort of feel like if it was easy to do, or there were models that really worked, you know, a bunch of us would see somebody else do it and adopt it and do it. But in fact, none of us are really doing it right. So I don't really have an answer, but I'm delighted that you highlighted the question, because I think these are really good questions. Are we doing the right things? Are we doing enough to train our students for what I showed you, which is the majority of our students, when you add them together, are working in health systems and in the private sector. And I do think that it is important that we think about that.
And the last, this whole series of discussions actually brings to mind the 2012 Lancet Commission on the Future of Health Professions, which is all about interprofessional education, how we need to be working in teams in the future. But unfortunately, at least in my view, health economics has completely stood in the way. I mean, that's for sure in this country. Let's move to Elahe Nezami. Professor Nezami.
I want to thank you, Sandro, for your amazing presentation as well. And if you allow me, I want to follow a trend of the information you provided today to us that leads to my question. You established the importance of public health with clear data on its contribution to health in our nation. Your presentation also provided clear data on the student interest in public health, which is evidenced by the number of applicants and a very promising sign of increased diversity in our applications. You also pointed out to the incentives that now exist for non-restricted funds, leading to substantial increase in the number of CEF accredited programs. An interesting phenomenon is the increase in the number of undergraduate students, which I'm most passionate about. And here at USC, we graduated our first cohort of undergraduate students in 1999. In reference to point 3 of the framing of the future for 2030, we have expanded reach for and visibility and impact of public health We have created 8 minors and 3 general education courses that are open to all USC students. Also, in following the #1 point for excellence through an anti-racism lens, we have started creating courses that focus on race, racism, and health. And now here comes my $1 million question. Considering the post-pandemic interest in public health, what should be our collective strategy? And what I mean by collective strategy is all of the undergraduate programs that have public health degrees, as well as SEAF, in looking at the focus on public health undergraduate education to make it as a more prominent academic discipline with its great potential as a platform to teach critical thinking, problem solving, communications skills, while we're expanding our presence in the general education world of our universities.
Yeah, thank you. Thank you for the kind words of Nezami, and thank you for actually there was a phenomenal distillate of my presentation. Thank you. I actually appreciate it. I think you've hit on something really critical, and I think you've hit on the need for us to commit to excellence in population health science. I tend to think of population health science as being the foundational science of our discipline, in much the same way as sort of biomedical research is the foundational discipline for medicine. And I think we should not compromise on anything but excellence on that. And we have a responsibility to be excellent in our own scholarship, but also to prepare our students for excellence. Now, these are difficult times they are challenging times to talk about excellence. But I contend that excellence does not have to be at odds with many of the other exigencies of the moment. I think there's the term that's used, which is inclusive excellence. All these terms, unfortunately, become a little bit hackneyed. But I think our job is not to pander to our students. Our job is to embrace our students' interest in creating a better world and teach them how to be excellent so they can do better at creating a better world. And that is frankly harder because the moment calls for seeing things differently. And seeing things differently while maintaining excellence is not easy. I think it's an active evolution every day. And I think that is how we are going to be as a field of academic public health, relevant and interesting going forward. But it is, I've been in academic public health for 20 years, and there's no question that this is the hardest moment. This is, to my mind, it's an order of magnitude harder because the moment demands excellence during a time of rapid churn and evolution of how we think and how we see.
Sandro, thank you. And now I'm going to turn with our remaining minutes to some of the questions. As a reflection of the far reach of the interest in this event, we have a question from a student, actually several questions from a student from the University of Albany School of Public Health, but I'll pick up on her last one, which was more of an observation that in fact, there's probably a goodness to having our students filter into the private world of healthcare and private business, because that's actually an opportunity to imbue all these other sectors with our perspective on the importance of population health, on the importance of looking at disparities in the experience of different sectors, different racial and ethnic groups in a population. And I would say there's some truth to that, particularly with respect to the undergraduate education, since so many of the graduates end up going to medical school, law school, business school, or something else. How would you comment on that?
Somebody gave me this metaphor, which I actually quite liked, and said, if you think of public health as a little bit like psychology degrees, psychology is the most popular undergraduate, and the vast majority of people who study psychology don't end up becoming psychologists. but probably the world is a better place for having more people learning psychology. I think the world is a better place for having more people learning public health. And I think this is true for people learning public health, go into private sector, go into the health systems in general. So I think there's an opportunity here for us. I mean, if interest in public health continues, if public interest in public health grows, that part of our job becomes teaching the world about how health is generated through the world around us. And that creates an enormous opportunity for there to be a better world. I keep waiting for the presidential election when in the debates, candidates argue about housing policy because of its effect on health. I feel like when that happens, we'll have made headway. And it's not far. It's not far. I mean, in the last, I thought last presidential debates, the Democratic debates, they were like, you know, they were sort of inching closer there. But, you know, for us, this is lingua franca, but it's not in general public, but it's coming. It's coming.
And for our last question, our student, Elahe Rodriguez, would like to have you discuss the opportunities to work at the intersection of public health and medicine. And in fact, going beyond that, what are medical schools thinking about? A lot of them are paying attention to sort of the disparities, paying more attention to the social determinants of health, but does that really mean that they're embracing our perspective and in population health? What's your experience?
Yeah, it's a terrific question. I think medical schools do talk that talk. Whether they actually walk that walk, I don't know. I think there's a real heterogeneity in medicine about that. I think it depends on the medical school. In truth, and you know, there's a lot of medical schools. But in terms of the opportunity, I think for a student who understands population health science and who is interested in bridging that between that and medicine. It's sorry, I was distracted by the comment in the chat, which was fun. I think there's a lot of opportunity, and you know, I am jealous of those of you who are students coming into public health right now, because I think there is enormous opportunity for you to be creative and to tell the story of public health. You know, when I showed that panoply of books that I think tell the story of health ultra lens of medicine, in the next decade, that's going to change. It's going to change because our students are going to change that. Our students who are going to emerge in public health are going to tell the story of public health, and they're going to influence medicine as a result. I think public health needs to stop waiting for medicine to lead on this, and I think we just need to lead medicine.
Panelists, thank you. Attendees, thank you. And Professor Sandro Galea, thank you so much for this incredible event and your participation. We'll see all of you next time at the next grand rounds for population and public health. And this is an opportunity for all of us to strengthen and promote the public health profession as we become your philanthropic partners, mentors, and we all participate in our professional education sessions going forward. Thanks again. Sandro, we'll see you at the next event.